Great to see everybody joining us. Welcome to your first concurrent presentation. We are really excited to see so many folks with us, and you made a really good decision to attend this one. In this session, Dr. Jenny Sprang will share about her research on organizational efforts to reduce secondary traumatic stress. I hope this is the session you wanted to attend, but if you have found yourself in the wrong spot and really wanted to go see Jim Harris's session, you can still access it on the Summit website agenda. So Jenna will place that link in the chat just in case you meant to go see Jim. Okay, we just wanted to give you a friendly reminder about the Zoom logistics on the next slide. So please be sure to share your comments with everyone when you use the chat function so everyone can see your message. Later, we might have a little bit of time for Q&A. So if you have any burning questions, you can also use the Q&A button and we'll be monitoring those. Closed captioning is also available by clicking on the closed caption button at the bottom of your screen and then click on show the subtitle button. And it is my pleasure now to introduce Dr. Jenny Sprang. She's a professor in the College of Medicine's Department of Psychiatry at the University of Kentucky and executive director of the university's Center on Trauma and Children. In her spare time, she is also the principal investigator of the SAMHSA-funded Secondary Traumatic Stress Innovations and Solutions Center, the Child and Adolescent Trauma Treatment and Training Institute, and the chair emeritus of the Secondary Traumatic Stress Collaborative Group. Jenny, I don't know how you do it all, but we're so looking forward to this presentation. And thank you so much for being here and sharing your research with us. The virtual floor is yours now.
Thank you, Michelle. And you can go to the next slide. So good afternoon, everyone. So just want to welcome everyone to the presentation. And we're going to be taking a deep dive into talking about secondary traumatic stress. And as you know, or as you probably have heard, that, STS, which I'll call it, is really this expected occupational hazard for anybody who is exposed to the traumatic material and experiences of other people. And so it's not, will you be affected? It is, when will you be affected and how severe will you be affected? It's not something that you should feel stigma about. It's just a naturally occurring condition for people that are doing the kind of work that we're all doing. And so secondary traumatic stress, as you know, can lead to a range of really bad outcomes for organizations, things like turnover, lots of absenteeism, and what's even worse, something we call presenteeism. That's when people come to work, but they're not really there because of what's going on with them emotionally. It impacts, employees, it impacts their mental health and their well-being. And we know that if professionals cannot operate at their best, if they're feeling avoidant, if they're suffering because of their work, then our students and the children that we serve are also negatively impacted. So the literature is full of examples of how organizational change is really this reciprocal interaction between things that people in a system do and what the organization does, and how these things work together to produce positive outcomes. But within the field of trauma-informed care, trauma-sensitive schools, safe and supportive schools, regardless of the literature that you look at, there's very little, if any, documentation of how do these efforts towards being trauma-informed and secondary trauma-informed really impact the workforce. So this is what this study that I'm going to tell you about is all about. I'm going to tell you a little bit about our process of organizational change and a lot of strategies. So just want to acknowledge my co-authors here, Fei-Tong Lei and Dr. Heather Bush, who worked with me on this article that's just appearing this year in the American Journal of Orthopsychiatry, if you want more information. Next slide, please. So I mentioned in the panel that I like to talk about a bifocal approach to addressing secondary traumatic stress. And as you can see, it's this interaction, this real reciprocal kind of very connected and transactional relationship between what a school or an organization does and what individuals do. So we always start off with a good organizational assessment. I think that's really important for schools to know how STS informed they are. Many schools have lots of initiatives already going. And so there's a tool that we use called the Secondary Traumatic Stress Informed Organizational Assessment that I will share. I'm going to put in a link in the chat. It's a free assessment tool. You can just go to my website and download it, use it however you want. Very straightforward. It'll give you kind of a glimpse into areas of strength and opportunity within your school. We want leaders there to provide good support. And I talked earlier about role modeling and being honest brokers and being champions. But there are practices that the leaders can do within a school that can really promote and help sustain any type of trauma-informed care or secondary trauma-informed care initiative. We expect things to be data-driven. No school is alike, no community is alike, no student population is alike. So we want what we do to be data-driven, and we always want to be monitoring the trends in a school. So that's all on the organizational side. On the individual side, we want to empower individuals, teachers, guidance counselors, social workers, friskies, and anyone to be able to self-administer assessment tools. We don't want people to be exposed or have to divulge these scores to anyone. It should be private and confidential. We want to make sure that we're educating people early so they understand this is a normal occupational hazard. And there should be no stigma if you're feeling some trauma symptoms because of your exposure to students. There's practice strategies. These are things that you do in the moment so that you can metabolize an experience. Some examples here are mindfulness, stress, relaxation types of techniques, CSERT, practice what you preach, Resilience Alliance, resilience building activities. Those are all part of things that we do in the moment so we don't have to take home these memories and these stories and ruminate about them and let them interfere with our family life and our wellness. And then there's formal interventions. So some people who may develop secondary traumatic stress may need some trauma treatment. And we have good trauma treatments. EMDR, cognitive processing therapy, prolonged exposures are kind of the gold standards there. And so we want to make sure that if people are reaching that level, they're getting referrals for formal interventions. Next slide, please. So the purpose of the study that we did was really to investigate how organizational efforts towards becoming more STS informed would impact the secondary traumatic stress and burnout symptoms in those that were receiving and part of this change initiative. And we really wanted to see what are the things that are happening behind the scenes, what we call implementation activity, and what role that plays in achieving these outcomes. So there's some things we needed to think about, and I want to just raise these for you. So this is kind of your background information here. We were really looking to achieve some conceptual clarity here. Secondary traumatic stress is very different than burnout. Burnout is from working long hours with low resources and beginning to feel emotionally exhausted and have low job satisfaction as a result. It's not a trauma phenomenon. Secondary traumatic stress is. So we feel like these two conditions would react differently to different interventions. We wanted to understand the maintenance of secondary traumatic stress. So if you begin to change, what do we know about what will sustain any positive change over time. And then we also wanted to think about what interventions are effective, because we know that formal interventions for sub-threshold level secondary traumatic stress are kind of far and few, that people are really still focusing on that wellness health promotion literature. So this study is really looking at both process and content. Next slide, please. So secondary traumatic stress, an important thing to think about is that some people are exposed to the trauma experiences of others and they have no symptoms, or their symptoms are so mild they don't even last a day or 24 hours. That is about 15% of people overall across professions. Some people at the other end of the continuum will experience full-blown post-traumatic stress disorder. They'll meet that criteria. That's between 15 and 20%. That means that majority of people that are exposed to indirect trauma exposure are going to fall in the middle. This is over 60% of folks are going to have trauma symptoms, but it doesn't impact their functioning, or they have trauma symptoms that are severe enough that it's causing them problems at home, in their friend networks, and at work. So we know that secondary traumatic stress across all different types of professional groups is an issue that's making a significant impact on the health and well-being of folks. Next slide. So the secondary traumatic stress informed organizational assessment really has some different domains. So the first domain is around resilience building. And so these are activities that a school could do to increase the resilience of their staff. Then we have a cluster of activities that fall into safety domain. And these are things that increase both the psychological and physical safety of an individual. We have the practice of leaders, and what are leaders doing to promote a secondary trauma-informed organization. There are those practices, organizational practices that the organization does, like how they conduct business, how they interact with staff among departments. Those organizational practices can promote secondary trauma, and we've identified some that are very specific to that. And then we're also interested in the degree to which policy might, STS-informed policy is at play. So how good is a school at taking these healthy practices and codifying them or institutionalizing them so that they're there beyond any one initiative? And then finally, as I mentioned earlier, are schools paying attention to trends? Are they monitoring for STS? Are they paying attention to turnover and absenteeism and presenteeism? Next slide, please. So during our change process, we are using the Institute for Healthcare Innovations Breakthrough Series collaborative model. We're doing this in schools throughout Kentucky, but we're also doing it all over the country with all different types of groups. And so I'm going to go ahead and say next. Michelle, if you go ahead and just put these arrows in. Where the red arrows are, this is where we're administering measures. So we're starting a process where we look at readiness, we enroll people in our change initiative, we do some baseline testing to see how STS informed they are, how the levels of secondary traumatic stress and burnout, their turnover intentions. We do some pre-work. We have learning sessions 1 and 2 and 3 with these action periods in between. And then right before action period 3, we're doing more data collection to see if any of these initiatives have made a difference, administering the same measures again. So this will help the data make sense. Next. And we're also using the CFR implementation research framework to think about the process, who's involved, the role of champions, the activities of the team, how much activity that they're actually engaging in. Next slide, please. So here are the hypotheses of the study. The first is that we hypothesize that as these organizational scores increase, so as an organization becomes more STS informed, that there would be less secondary traumatic stress when we control for time, age, and sex. And so we're doing that because we want to make sure this, not because of other kind of variables. It really has to do with the variable of interest, which is what the organization is doing. The second is that we want to see if these organizational efforts create a change in burnout, again, controlling for these demographics. Hypothesis 3 is that higher levels of implementation activity by the teams would predict these effects, so that we would see the high implementers do better than the low implementers. And then finally, I told you about those domains of the STSIOA, where we were hypothesizing that safety, the safety domain, would be the most robust predictor of change. So those activities that the organizations were doing to promote physical and psychological safety would be most powerful. And the idea there is safety is foundational. Next slide, please. So here's our methodology. We have about a little over 2,300 records. This is a quantitative study. We had these measures, the STSIOA, which I've already told you about. We used the STSS and the Procol burnout scores. And then we created our own implementation activity index based on the CEPR model that I just told you about. So in this particular sample, we've got a wide range of professionals, including some school-based mental health therapists. We used ANOVA and linear mixed models for our analysis. You can go to the next slide. So I just wanted to show you this. This is what we call a dashboard. So when I told you we did a baseline assessment. So we would administer our baseline assessment, and then every team got one of these. And what this is this is a kind of the state of things at their school. So we tell them who responded. We tell them, what their STSI organizational score was. And we kind of tell them what percentile they fall into, the level of exposure that folks are reporting. Then we give them their secondary traumatic stress scores and their burnout scores. These are the averages for the population of employees. And then we do lots of analysis, and we try to identify, are certain people in the organization more likely to report higher scores. This is because when we start our change efforts, we want to drill down and get it right to the people that are suffering the most. Next slide. But because not everybody likes data, and some people get overwhelmed with all the data, we take each item of the STSIOA, we color code it based on the item mean, and we create an organizational house for them. And each room of the house is a domain of activities that tie back to the STSIOA. So if it's red, it means nothing's happening here. This is something that needs attention. Orange means we're talking about it, but we're really not doing anything yet. Yellow means there's isolated efforts, but nothing has really been tested. And then green means the strategy is in play and it's been tested and it's ready for spread. Next slide. So what we want to see is that over time that these houses go from red and orange to green and yellow. So time 1 is at baseline, and time 2 was this organization score when they finished the initiative. Next slide. So let me just talk to you a little bit about what we found, because we did a lot of analysis, and I'm not going to go through lots of detail here, but I just hit the highlights for you. So we know that most of the people that participated were similar across time points. So we measured that at baseline, at the end of the initiative, and then 5 months later, so we could see if changes were sustained. Mostly females participants, but we had a nice range of leadership, frontline, middle management, and a good diversity of organizations and size of organizations. Next slide. What we saw over time is that there was statistically significant improvements in organizational scores. This is the STS-IOA, as well as all of the domain scores. So people got better at follow-up and at baseline. From baseline to end of initiative, they got better, and then also at follow-up. And this was true for both secondary traumatic stress and burnout. When we looked, though, at kind of the organizational level trajectory that we would call it, we found that for every 10-point increase in the organization's score, we saw a 1-point reduction in secondary traumatic stress. So that's exactly what we want to see. As the organizations were becoming more STS informed, the level of secondary trauma was going down in the workforce. So that was like great news. But we didn't see the same thing for burnout. Burnout did get better, but it didn't change in a statistically significant way. Next slide. We also were able to observe over time that organizations with moderate or very high implementation activity were able to kind of improve their scores even beyond the end of the initiative. So as the coaches and consultants moved out, these champions teams led by a senior leader were able to sustain the change. So the green line here is this high activity team, and you can see how their scores continue to drop. Whereas the blue line, these are the people that were low implementers. You can see their scores didn't really change from the end of the initiative to follow up. Next slide. And I told you that I thought safety was foundational. I was partly right. So all of the domains were significantly predicting lower STS scores, but safety wasn't the most robust predictor. So they actually, all of them were making a big difference. Next slide. And so if we revisit our hypotheses, and I'm just going to say next 4 times, what we can see is that our hypothesis 1 was supported, our hypothesis 3 was supported, our hypothesis that the STS-IOA scores would reduce burnout was not supported. That didn't happen. They got better, but not statistically significant. So, and safety was a predictor, but not the most robust predictor. So next slide. So what does it mean? It means that both the process and the content were really tailored. We used a data-driven approach. We didn't use any one interventions. We used lots of micro interventions that were based on what the organization needed. The fact that STS, it was improving, but not burnout, it kind of makes sense because the initiatives that were taken by the team were really focused on secondary trauma, because burnout in this group was moderately low. It was not the issue of concern. That high implementers were able to sustain the change over time, even without any kind of formal intervention. That's what we want to see. And, our next step is to see if this continues, even a year later or 2 years later. And safety is important, but really, if you're going to start to make change, jump in wherever you want. The sequencing doesn't matter. We thought that it might. Next slide. So that's all I have. I'm sharing with you here the link to the STS-IOA. It's like I said, it's a free download. And so I'm happy, for you to use that any way that you would like. I've also put my contact information here if you want to reach out. And I see Jenna just put that in the chat as well.
Ginny, thank you so much. That was a presentation chock full of information. We actually have probably 1 or 2 minutes for any burning questions. If there's anything that any audience member would like to ask, please put it in the chat or in the Q&A. And while we're waiting for those to come up, I just have a question for you, Ginny. The STS-IO is such a helpful tool, it seems, excuse me, for assessing and suggesting specific concrete strategies to improve practices and policies. How do you similarly measure, though, the individual's practices and their abilities, to play a part in that reciprocal transactional relationship?
That is a great question. I think within, if you remember that, if you go back one slide, I can kind of point to it in that bifocal model that I have here. We have practice strategies. And within these practice strategies, each one of them has their own measurement system. So if you're using CSERT, for example, you're paying attention to how many times you ruminate. And you're paying attention to how many times you're using a task positive response. If it's mindfulness-based stress reduction, they have their own ways to subjective units of distress to keep track of that. And Practice What You Preach has thought records where you're recording, your thoughts and then measuring your subjective units of distress as a result. So I think within a particular micro intervention, there's all kinds of ways for measurement that an individual can employ.
Thank you. And then there's another great question. Is it possible to tailor these supports for specific populations of educators, meaning educators who are culturally and linguistically diverse, LGBTQIA, neurodivergent educators?
Okay, so that's a lot of questions. So we have had the STS-IOA and the change process used across all different types of educators. And what we do is we create these teams where you have different people from the school represented. So you might have people on the team that maybe learn in different ways or have different types of challenges to learning, or that have just very specific needs because they're really focused on one population. And we want that because we want the teams to represent the breadth of what the school is doing. I will say we've also translated it into different languages, and we do have a pandemic version of it for people that are doing this in the COVID context.
That's really great. And one other question, you told us about the proportion that you usually see that suffer from secondary traumatic stress all the way to the PTSD level, but did your study show any certain characteristics of folks that might be more likely to report high STS based on some characteristics?
Yeah, that's a really good question. So we know across the literature and in this study that we tend to see females and those with lower years of experience, fewer years of experience, report the highest levels of secondary traumatic stress. So there's some possible explanations for that, but basically it's because, with women, it may be about reporting, but it may be prior trauma history because women are exposed to more salient traumatic events than men with sexual abuse, being a high prevalence.
All right, Ginny, thank you so much again for such an informative, chock-full presentation. You all, we have about a 30-minute break now. And if you want to stay for just an additional minute, I'll give you a little bit of an overview again about logistics, just to make sure that you're all acquainted and know what's next and where to go. We have a 30-minute break right now. And after the break, we get to choose among 3 concurrent presentations. But we do encourage you for this 30-minute break to take a look and try out a 15-minute pre-recorded mindful moment. It's a really helpful guided meditation session presented by our own Dr. Victoria Schaefer. To access it, please follow the link in the chat or just go directly to the resource tab, the mindful resource tab on the Summit website. The concurrent sessions are really going to be devoted to learning how to implement, use some tools and resources to implement some services and supports in real world experiences. So there's an option of looking at some CSOC resources developed on addressing trauma in the classroom and the Handle with Care program. You can also get a chance to mobilize and navigate yourself through the SHAPE program, a web-based tool to assess trauma-informed approaches developed by our colleagues at the National Center for School Mental Health. Or you can look at some tools and some guided resources on how to form effective school community partnerships to advance comprehensive trauma-informed care in your schools and communities. So I know that's a really tough choice, and they're all going to be incredibly helpful sessions. So please choose wisely and don't be late. We'll start right after the break at 1:30 p.m. Eastern, and we'll put some of the links in the chat to help you look at those agendas and abstracts to make your decision wisely. After those concurrent presentations, just so you'll know, we'll have a short break again, and we'll return to the full group for our final keynote presentation by Michael Meat. You really don't want to miss it, so please try to stick around for the whole day. Dr. Meat will provide us with the latest statistics on the opioid epidemic in Appalachia, and those findings are really sort of a bellwether of the state of the health of our entire nation. So whether you reside and work in Appalachia or beyond, I think it's going to be a really important session. He'll give us more inspiration to continue the important work we're all doing. So that will take place at 2:45 p.m. Eastern. That's 11:45 p.m. for you West Coasters. If anybody's having any technical issues or need help in general, have some questions to ask of us, we got folks manning this REL AP email address. It's cssoc or ccsoc.relap@sri.com. We're here to help. So go off, have a mindful meditation break if you can, grab a snack, some water, and please be back in about half an hour with your chosen concurrent presentation session. Thanks, everybody. Thank you, Jenny.